Good afternoon. Today, we'll be going through your comprehensive exam. That's 115 items. We hope that you've learned a lot from the previous discussions. Thanks, of course, to our very diligent lecturers. So, without further ado, let's start with the mini discussion. For number 1, what component of a freezing point osmometer measures the sample temperature? Again, for number 1, what component of a freezing point osmometer measures the sample temperature? Choices: is it letter A, thermistor, letter B, thermocouple, letter C, capacitor, or letter D, electrode? Again, what component of a freezing point osmometer measures the sample temperature? Correct answer is letter A, thermistor. Again, for number 1, the correct answer is letter A, thermistor. So let us define first some important terms. First, we have osmometry. Osmometry is the measurement of particle concentration that is related to the osmotic pressure of the solution. Osmotic pressure, this regulates the movement of a solvent across a membrane. Now remember, osmotic pressure is a colligative property. When we say colligative properties of a solution, these are related to the number of solute particles per kilogram of solvent. Now, other than osmotic pressure, colligative properties include, we have boiling point, vapor pressure, and freezing point. Again, colligative properties are intensive properties that change as the number of particles in the solution change too. Now, in the clinical chemistry laboratory, vapor pressure and freezing point are the colligative properties of interest, and these can be measured in an osmometer. So we use freezing point depression. In freezing point depression, remember, the more particles in solution, the lower the freezing point of the solution. On the other hand, with vapor pressure depression, increased particles in a solution prevent solvent evaporation. So let us define osmolality. So osmolality is a measurement of the total solute concentrations dissolved in a solvent, or how do we say this? Osmolality is a general measure of the particle concentration in a solute. So it describes the number of moles of particle per kilogram of water, and it depends only on the number of particles, not on what types of particles are present. Or in other words, it's not depending on the nature or identity of the molecules, but just their number. So therefore, a 2-molar solution of a non-dissociating molecule, as you can see there, has the same osmolality as a 1-molar solution of a fully dissociating salt composed of 2 ions. You can see there. Now, the osmolality of a solution is the same even when the molecules vary in shape, as well as in size. So therefore, take note, all solutions containing the same number of osmotically active particles, regardless of their chemical properties, exhibit the same osmolality. We also have osmolar gap. When we say osmolar gap, this is the difference between the calculated osmolality and the actual measured osmolality. Now, an approximation of serum osmolality can be calculated. or the formula for calculated plasma osmolality is, so we have 2 sodium or 1.8 sodium plus glucose over 20 plus BUN over 3, or that's glucose over 18 plus BUN over 2.8. Now remember, if the osmolar gap is greater than 0, there is an indication of abnormal concentration of unmeasured substances, typically ethanol in the blood. So again, serum osmolality can be measured more accurately in a laboratory setting by using a device we know as freezing point depression osmometer. Now in a freezing point depression osmometer, a sample of serum is introduced to a cooling chamber with microprocessor controlled element, and where it is cooled to a temperature below its expected freezing point. Again, during this process, the solution is super cooled below 0 degrees Celsius while still being liquid. Now, at a certain temperature, the freezing process is initiated by a rotation of the steering wire. This steering causes the sample to become partially crystallized. Now, the formation of ice crystals causes the release of thermal energy, and the heat generated from this brings the sample to a temperature that is actually equal to its freezing point. And then, after a short period of time, an equilibrium is reached where melting and thawing of ice crystals are balanced, and the sample's temperature stays constant. So this plateau marks the real freezing point of the sample. Now, during the whole process, the temperature of the solution is measured by a high-precision thermistor. Now, remember, this thermistor is temperature sensitive. So, the resistance to current flow is inversely proportional po to the temperature, such that the resistance to current flow increases po as the temperature falls. So, pag mataas po yung resistance to current flow, mababa naman po yung temperature. So, the temperature po at which a solution freezes naman can be determined by measuring the resistance of the thermistor. Take note po, resistance naman is directly proportional to the osmolality of the sample. So, pag increase po yung resistance ng current flow, increase naman po yung osmolality. Now, the resistance of the thermistor po is measured using a network of resistors we call as Wheatstone bridge po. Now, when the sample is frozen, the bridge is balanced po using a calibrated variable resistor so that no current flows to the readout. So, the resistance required to balance the meter is equal to the resistance of the thermistor po. And thanks to the resolution, okay, the freezing point temperature po is exactly determined, and even small differences between osmolality of the two samples can be measured. So the normal values, of course, of serum osmolality can range from 280 to 300 milliosmoles per kilogram of water. Also, a wide array of medical conditions can lead to abnormally high or low serum osmolality po. So there are 2 endocrine diseases that can alter the serum osmolality. We have the SIAD or SIADH, which stands for Syndrome of Inappropriate Antidiuretic Hormone Hypersecretion po. In SIAD, okay, this condition is where free water po is abnormally retained by the kidneys po. And we also have, by the way, this SIAD is also characterized by low serum sodium levels po. And we have diabetes mellitus po, which is a condition po that occurs when the pancreas no longer produces enough insulin, or when the body does not respond to the insulin po that is produced by the pancreas po. So, of course, this causes the serum glucose to remain elevated. So, Example, a sample of serum has 140 MEq per dl of sodium, 90 MEq per dl of glucose, and 14 MEq per dl of urea. Now, what is the osmolality of this sample? Is it letter A, 300 milliosmoles per kilogram of water, letter B, 290 milliosmoles per kilogram of water, letter C, 270 milliosmole per kilogram of water, or letter D, 280 milliosmole per kilogram of water? Remember, we use the formula 2 sodium or 1.8 sodium plus glucose over 20 plus BUN over 3. Okay, so substituting the given, we have 2 times 140 plus 90 over 20 plus 14 over 3. Approximately, we get around 289 milliosmoles per kilogram. So the correct answer would be letter B. Again, correct answer is letter B. For number 2, which of the following isolates light within a narrow region of the spectrum? Again, which of the following isolates light within a narrow region of the spectrum? Choices. Is it letter A, photomultiplier tube, letter B, monochromator, letter C, photovoltaic cell, letter D, detector? Again, keyword po natin isolates light. Of course, the correct answer is letter B, monochromator po. Again, for number 2 po, letter B, monochromator. So now going to just a forward of automation. So automation po in the clinical chemistry laboratory context po is the mechanization of chemical analysis po, of course, to minimize manual work or manual manipulation po. So of course, we have yung advantages po and disadvantages po ng automation po. So that includes, example po ng advantage of automation, of course, we have increased work capacity per unit of time, minimized variability, reduced errors, of course, caused by manual manipulations, reduced sample volumes, and reduced consumable cost. Now, for disadvantages naman ng automation, of course, the initial cost, discontinuity, of course, of the product, technical skill required. So, yun po. Now, there are two basic approaches po to automation in use today. So, we are familiar naman po with the continuous flow analyzer po. So continuous flow analyzer, remember, this type of analyzer uses liquid reagents po pumped through a continuous system of tubing. Again, yung keyword po natin for continuous flow analyzer is continuous system of tubing, where each sample is introduced in a sequential manner. Discrete analyzers. So aside from continuous flow analyzer po, we also have discrete analyzers. Discrete analyzers naman po house samples and reagents in separate containers. And reagents in separate containers po. So pinaka-common po na ginagamit sa ine-employ sa clinical laboratory is discrete analyzer po. Also, in discrete analyzers po, multiple tests can be performed on a single sample po. So, yun na po yung tinatawag nating random access testing or random access analysis. Or, pwede ding one test naman po can be selected to perform on multiple samples. We call that naman as batch analysis. Also, we have yung LIS, tama? The Laboratory Information System, which is a computer software system designed to handle lab data. So this LIS, of course, serves to include, first, we have database ng patient information, also compilation of specimen test results, and we have production of patient reports. So a spectrophotometer is used to measure the concentration of a known substance in a solution. So it is an instrument that measures the transmitted light of a solution and it allows the operator to read the absorbance of the solution on a meter. So they do this by passing a light through the substance, kung makikita nyo po, and measuring light intensity po as a function of wavelength. Now, a spectrophotometer po, kaya spectrophotometer ang tawag because it's made up of two instruments, a spectrometer and a photometer. A spectrometer po is used to produce light of any wavelength po. Again, to produce light of any wavelength. Ang photometer naman po, on the other hand, is used to measure the intensity of the light. Again, photometer is used to measure the intensity of the light. Now, this spectrophotometer po is designed in a way po that the liquid or the sample may be placed between the spectrometer and the photometer. Now again, the photometer measures the amount of light that passes through the sample po and it delivers a voltage signal to the display po. So again, photometer yung nagde-deliver ng voltage signal to the display. So if the absorbing of light changes po, the voltage signal also changes. Also take note for spectrophotometer, we use either single beam spectrophotometer, right? Familiar naman po tayo, and double beam spectrophotometers. Now, single beam spectrophotometer is uses a reference standard po to measure light intensity before and after the sample is loaded. Ang double beam spectrophotometer, on the other hand, okay, in here the beam is split with one beam passing through the standard and the other through the sample to compare intensities po. Now, while single beam spectrophotometers are typically less expensive po and have higher sensitivity, double beam spectrophotometers tend to be more stable and are easier to use. So the basic spectrophotometer instrument consists of a light source. We have a digital display, a monochromator, a wavelength sector to transmit selected wavelength po. We also have a collimator. Collimator po is used for straight light beam transmission po. We also have photoelectric detector and of course, lastly, a cuvette po. Again, a cuvette to place a sample po. So, let's go to the first component po, okay, of the spectrophotometer. So, light source. Now, this light source, remember, provides wavelengths of light at great intensity that span from near-infrared po to within the UV range po. Kasama na rin po yung visible light spectrum. In other words po, light source provides radiant energy. Again, light source po provides radiant energy. So, examples po ng light source. Okay, so we have under niya, we have continuum and line. Under continuum, we have tungsten light bulb, we have deuterium lamp, we have xenon lamp po. Okay, so para saan si tungsten light bulb? Tungsten light bulb is used for visible and near infrared regions po. We also have under continuum light source, we have deuterium lamp. Deuterium lamp naman po, ginagamit for UV regions po. Again, ginagamit naman po for UV regions. And we also have xenon lamp. Xenon lamp, on the other hand, is used for visible and UV regions po. And underline light sources po, we have two. We have mercury and sodium vapor lamps and hollow cathode lamp po. Now, mercury and sodium vapor lamps ay ginagamit po for visible and UV regions po. And hollow cathode lamp naman po ay ginagamit for AAS po. So next, let's go to monochromators. Now, monochromators a monochromator separates po the light source into specific portions of the spectrum. Or in other words, a monochromator serves to isolate the wavelength of interest po. So examples po ng monochromators, we have prisms, we have diffraction gratings, we have interference filters, holographic gratings, and even glass filters po. Now remember, diffraction gratings have better resolution than prism po. Again, in terms of resolution po, mas okay si diffraction gratings. Now filters naman, considered as simple, least expensive, not precise, but useful. So let's go to prism monochromator. So in a prism monochromator, as you can see, different wavelengths of radiations have different values of refractive index in a medium. So this entrance slit, again, the entrance slit allows the source radiation to illuminate the first lens. And the first lens collimates the light, spreading it across the face of the prism. Now this prism disperses radiation into component wavelengths. And the second lens focuses the spectrum at the focal plane. Now, an exit slit selects the band of radiation to reach the detector. So if you are asked, what type of monochromator produces the purest monochromatic light in the UV range? Again, what type of monochromator produces the purest monochromatic light in the UV range? Correct answer is prism and variable exit slit. Also, take note, dispersing elements can be a prism or a diffraction grating. Again, they serve as dispersing elements. Focusing elements can be lenses or mirrors. So gratings gratings are based on interference and diffraction. So gratings usually consist of grooves in glass or quartz or a mirror. So yan, kita nyo may mga grooves. Yan, andyan po yung difference ng grating and prism po. So types of dispersion, uniform dispersion po for grating, and for prism, shorter and better separated dispersion po. Of course, smaller po si grating compared kay prisms po. And gratings have higher stray light compared to prism. That's why po, purest monochromatic light po in the UV range po, that's prism. And we also have the variable wavelength selector po. This variable wavelength selector po is found outside or in the exterior po of the instrument. So a variable wavelength selector po allows the instrument to essentially filter the light, transmitting light only at a specific wavelength or range of wavelengths of interest. So, pag ina-adjust po natin yung variable wavelength selector, you can actually change the position of the monochromator po. So, different wavelengths of light are directed towards the sample compartment containing the sample to be analyzed. And of course, we have the sample compartment po. Now, the sample compartment is where you place the cuvette. The cuvette is a transparent tube, of course, designed to hold the samples, which contains the analyte. Now, by the way, the sample cell may contain the solution in the cuvette, maybe po in the tubing or in plastic, in the form of plastic packs. Now, selected wavelengths of light pass through the analyte for detection by a photo detector. So we have the detectors or photodetectors. Now, light passing through the analyte strikes a photodetector. Now, electrons in this we call as semiconducting material po are excited proportionally to the wavelength of the light striking the photodetector. As we increase po yung light intensity, it generates more electrons po, and translating to a higher current that is received by the signal processor. Or in other words, photodetector converts radiant energy to electrical energy po. So there are three main types of photodetectors. We have photocell or the barrier layer cell. We have the phototube and the photo multiplier tube. Of course, the barrier layer cell is considered the simplest, least expensive, and temperature sensitive po. Phototube requires external voltage for operation. And we have the photodiode po. Remember, photodiode is not as sensitive as the photo multiplier tube, but with excellent linearity. And we also have the display or readout device. Simply, the display or readout device, this is where both the transmittance and absorbance of a sample po are read. So let's go to the types of spectrophotometer. So we have absorption spectrophotometry and we have the atomic absorption spectrophotometry po. Now, the absorption spectrophotometry this is defined po as the measurement of radiant energy absorbed by a solution po. And this measurement, by the way, can be related to the concentration of a substance in the solution po, using, of course, the Beer's law. And we have yung atomic absorption spectrophotometry naman. This measures concentration through the detection of absorbance of electromagnetic radiation po by atoms. Again, by atoms po instead of molecules. So this is used to measure concentration of metals that are not easily excited. So of course in AAS, the element of interest po is dissociated po from its chemical bonds in the flame po. Then it is in an unexcited state. So at this low energy, the atom can absorb radiation po at a narrow specific bandwidth. And a wavelength of light specific for the atom po is absorbed by the low energy atoms in the flame po. Kaya this will result po in a decrease in the intensity of the light measured by the detector. Of course, for AAS, we have yung components niya. Tama, it needs a light source. Specifically yung light source po for AAS, we know that's hollow cathode lamp. Flame naman, this flame is produced by the burner head. We also have monochromator po, again under AAS, and photodetector po. Specifically yung photomultiplier tube. Okay, now we also use we also apply nephelometry, turbidimetry, and fluorometry po as miscellaneous applications po in the laboratory po. So nephelometry po, this is a method of measuring concentration po in terms of light energy scattered in a forward direction po. Again, in a forward direction by small particles in a solution. So the intensity, remember, of the in here in nephelometry, the intensity po of the scattered light po is directly proportional to the number of particles in a solution. On the other hand, turbidimetry naman po, this is a photometric measurement naman po of unscattered light or blocked light po, passing through a colloidal solution of small particles. Again, it is essentially po a measurement of black light po. And the amount of black light po is directly proportional to the number of particles in a solution po. And of course, we have fluorometry. Fluorometry po is the photometric measurement naman po of light emitted by a substance that has been previously excited by a source of UV light po. Now in here, sa fluorometry po, after this substance po is excited and driven po into a higher energy state po, yung molecule niya po loses energy po by fluorescing. Okay, and the amount of light po emitted, again, the amount of light emitted here is proportional to the concentration of the substance in a solution. Okay, for number 3, which of the following serum protein electrophoresis results suggests an acute inflammatory process? Again, which of the following serum protein electrophoresis results suggests an acute inflammatory process? Choices. Is it letter A, albumin decreased, alpha-1 increased, alpha-2 decreased, beta fraction and gamma fractions normal? Is it letter B, normal albumin, increased alpha-1, normal alpha-2, and increased beta and gamma fractions? Letter C, decreased albumin, increased alpha-1 and alpha-2, and normal beta and gamma fractions. And letter D, increased albumin, increased alpha-1 and alpha-2, and beta and gamma fractions. Ano kayong correct answer? Number 3, we have letter C po. So remember po, acute inflammation po is characterized by increased production of acute phase proteins po. So these include alpha-1 antitrypsin, alpha-1 acid glycoprotein, alpha-1 anti-chymotrypsin, and even haptoglobin po. Now albumin po is slightly decreased po. Again, albumin is slightly decreased in acute inflammation, while gamma and beta fractions po are normal. So for example po in MI, in myocardial infarction po, okay, this condition produces a pattern po of acute inflammation po, usually associated po with tissue injury po. Now this pattern results from production again of acute phase proteins, including alpha-1 antitrypsin, we have alpha-1 anti-chymotrypsin, and haptoglobin po. So again, acute inflammatory states can be seen in, other than MI, we have early infection po, in pregnancy, and even early nephritis po. Now, chronic inflammation, kung makikita nyo po, chronic inflammation is characterized by a diffuse polyclonal increase in immunoglobulin po, particularly in the gamma fraction po. So, anong mga conditions yung may ganitong pattern? Okay, for example po, yung may chronic inflammatory pattern, we have malignancy, we have rheumatoid arthritis, and hepatitis po. Again, malignancy, rheumatoid arthritis po, and hepatitis po are all associated with chronic inflammatory pattern po. So, this differs, yung sa chronic inflammatory pattern po, this differs from the acute pattern po by the addition po of, again, a polyclonal gammopathy po. Again, particularly po sa gamma fraction. Now, other significant electrophoretic patterns. Okay, so makita niyo yung naka-blue, that's the normal serum protein electrophoresis pattern. But those with multiple myeloma, kung mapapansin niyo, meron po tayong tinatawag na gamma spike. Again, gamma spike po for multiple myeloma po. So, increased po yung may spike po in the gamma. And also, okay, kung mapapansin nyo po, sa pattern na to, we have bridging. Bridging with the beta and gamma. We call that as beta-gamma bridging, which is usually seen po in cirrhosis po. Again, this pattern is seen in cirrhosis with, of course, diffuse increase po in immunoglobulins po, involving both IgA po and IgG po. So, IgA, of course, in the beta-gamma region po, and IgG in the gamma region. And we also have during immunodeficiency states po. Kung mapapansin niyo po na wala yung gamma fraction, yung gamma fraction po. Okay, so that's a gamma globulinemia po. Again, a gamma globulinemia which is suggestive of an immunodeficiency state. Now for number 4, a patient with hemolytic anemia will, again, a patient with hemolytic anemia will, choice letter A, show a decrease in glycated hemoglobin value. Letter B, show an increase in glycated hemoglobin value. Letter C, show little or no change in glycated hemoglobin value. Or letter D, demonstrate an elevated HbA1c value. Again, patient with hemolytic anemia will, take note, hemolytic anemia po, this will show a decrease in glycated hemoglobin value. So, let's go to the glycosylated hemoglobin or the glycated hemoglobin. So, to give you a forward of HbA1c, let's begin with hemoglobin muna. Okay, so hemoglobin, this is a tetramer po composed of 4 globin chains po and an embedded heme group. So, of course, we have hemoglobin A. Tama po ba? Hemoglobin A is composed of 2 alpha and 2 beta chains po. Hemoglobin A or hemoglobin A1 po is the most abundant form po of hemoglobin in most adults, which comprises approximately around 96% po of the total hemoglobin. And we have also hemoglobin A2. So hemoglobin A2 contains, of course, 2 alpha and 2 delta chains po. And we also have, of course, hemoglobin F, which contains 2 alpha and 2 gamma chains po, which hemoglobin F or the fetal hemoglobin po makes up the remaining 2% to 5% naman po. So remember po that the amino terminal po of the beta globin chains of hemoglobin A may undergo covalent linkages po. Again, this may undergo covalent linkages po. So hemoglobin A, the amino terminal of the beta globin chain of hemoglobin A may undergo covalent linkage with, for example po, with fructose 1,6-diphosphate to form hemoglobin A1 po. Or it may also form a hemoglobin A may undergo covalent linkage din po with glucose 6-phosphate po, forming hemoglobin A1A2 po. Also with pyruvic acid po. Again, with covalent linkage po with pyruvic acid po, forming hemoglobin A1AB. Hemoglobin A1B. Again, hemoglobin A1B, and of course, it may also form the beta globin chain po again of hemoglobin A may undergo covalent linkage po with glucose to form yung tinatawag natin hemoglobin A1C or the glycated hemoglobin or glycosylated hemoglobin po. So this glycated hemoglobin po This is the only product po formed by non-enzymatic irreversible glycation po. And it is formed as a result of a two-step reaction po. So, just a simple summary po of the biochemistry po of HbA1c po. So, glucose first binds to the terminal valine po of the hemoglobin beta chain po through an aldymmine linkage, yung tinatawag nating Schiff base. So, yung stable molecule na to, this undergoes an Amadori rearrangement po to form a stable ketoamines po. So, since this reaction does not rely on enzyme catalysis po, yung amount po ng Amadori product na mapo-form will depend only on the concentration po ng substrate po and the duration of the exposure po. So, in addition to this, hemoglobin A po remains glycated po until the destruction of the red blood cell po and the resultant hemoglobin catabolism po. Now, since yung average lifespan po, or because of the average lifespan po ng RBC po is approximately 120 days, yung single hemoglobin A1c measurement po can provide information about a patient's average blood glucose concentration over the several months preceding the test po. So, it should be noted also po that glycosylated hemoglobin po is the weighted measure of mean blood glucose po with more recent blood glucose concentrations contributing relatively po more sa value po kesa sa earlier values po. And approximately 50% po ng hemoglobin A1c po can be attributed po sa mean blood glucose during the 30 days before the test po. So there are several benefits po, of course, to measuring hemoglobin A1c po, which is, by the way, expressed as percentage of total hemoglobin po. So instead of, or in addition po to fasting po, or random blood glucose concentration for diabetes diagnosis po and monitoring po. So first, a fasting glucose measurement po, of course, requires the patient po to fast for, of course, 8 to 12 hours po before the test. Now, remember po yung fasting na to, this fasting samples po can be challenging po to collect. Kasi po yung patients po, of course, may not understand po or hindi po nila ma-comply yung mga instructions. So, particularly po if sample collection po occurs later po in the day. Now, the inability po of the patient to fast, of course, for an appropriate period of time before the collection of the blood can somehow distort the sensitivity and specificity of a fasting blood glucose measurement po. So, depending sa patient's nutritional status, not only nutritional, but also insulin and disease status po, a random blood glucose measurement po provides a snapshot measurement po. Again, provides a snapshot measurement po which can vary by more than 10-fold po within periods of hours po. So, hemoglobin A1c has become the glycemic control measure of choice po. Remember, because it is not labile po. Again, it's not labile over the course of the day po. And it, of course, does not require fasting po. So, it provides a single measure, a cumulative indication po ng patient's blood glucose status over a several-month period po. So, in patients with normal hemoglobin, lifespan and structure, hemoglobin A1c percentage po has become the useful supplement po to fasting blood glucose testing po. Pero of course, this percentage po is dependent pa rin po. Yung gamit po nito is dependent on a number of patient and methodology specific variables. So we have to consider these factors. So let's go to the factors affecting hemoglobin A1c measurement po. So patient characteristics that may affect the accuracy po of hemoglobin A1c measurements can be grouped into two categories. First, those that alter the accuracy po of the hemoglobin A1c measurement or yung interferences po. Yung second, those that decouple hemoglobin A1c from the actual cumulative blood glucose concentration po. Now remember, genetic hemoglobin variants po and modified hemoglobin derivatives po, they are the most common factors known to interfere with hemoglobin A1c measurement in the laboratory. Now, in contrast naman, conditions that can affect the mean age or lifespan of RBCs, again, those conditions that may affect the mean age or lifespan of the RBCs, for example po, hemolytic anemia, recent significant blood loss, or history po ng transfusion or blood donation, can affect po the clinical significance po of hemoglobin A1C concentrations po. Although at sometimes po the lab value po may not accurately reflect the patient's blood glucose status po. So specifically or generally, or in other words po, pag decreased po yung erythrocyte survival, or again in conditions with decreased erythrocyte survival po, this will have a falsely depressed or falsely decreased hemoglobin A1C values po. So also we have chronic kidney disease, cirrhosis, pregnancy, and iron deficiency po. They can also decouple hemoglobin A1C po from actual blood glucose concentration po. Now disease states affecting both the structure po and lifespan of hemoglobin. For example po, hemoglobin SS, hemoglobin SC, or hemoglobin CC po, they are subject po to both types po of limitation po. Yung interferences po and decoupling hemoglobin A1C po. So, adding another challenge naman po to this hemoglobin A1C interpretation po is yung variability po ng lifespan ng RBCs po in both diabetic po and non-diabetic po. With normal hemoglobin po. One study actually found that the mean age po ng circulating RBCs po can range from 38 to 60 days din sometimes. Again, it may range from 38 to 60 days po. So this is enough to cause clinically important differences po in hemoglobin A1C values for a given average blood glucose concentration po. So now let's go to the methodology-specific variables affecting hemoglobin A1C. By the way, this topic, hemoglobin A1C, usually comes out in the ASCP or AMT exam. That is why I'm giving you an overview. So, commercially available tests for hemoglobin A1C typically utilize one of 5 methods. We have immunoassays, ion exchange, high-performance liquid chromatography. We also have enzymatic assay. We have capillary electrophoresis and boronate affinity chromatography. So by the way, immunoassays are the most common method po. Immunoassays are the most common method po used in clinical lab testing of hemoglobin A1C. And that is according to the 2017 College of American Pathologists Proficiency Testing Program. Now, this type of assay uses a polyhapten agglutinator po, which contains multiple epitopes for the hemoglobin A1C. Now, remember here in immunoassays, the concentration of hemoglobin A1C po is inversely proportional to the turbidity of the specimen. So, pag increase ang concentration ng hemoglobin A1C, lesser naman ang turbidity. Again, inverse po yung relationship ng concentration ng hemoglobin A1C to the turbidity of the specimen. Now, under immunoassays, we have 2. We have first-generation immunoassays and we have second or third-generation immunoassays po. So, these first-generation immunoassays po used antibodies po that recognize amino acids 4 through 10 of the beta globin chain po. And they are susceptible to interference po from hemoglobin S, hemoglobin C, and other common hemoglobin variants that span this epitope. And however, we have yung secondary or second or third generation assays po. Naman, they use antibodies that bind to amino acids closer to the N terminus po. And they are not affected po by the most common hemoglobin variants po. And we also have the ion exchange HPLC po. This is currently the second most common type of assay po used in clinical practice. And by the way, ion exchange HPLC po separates hemoglobin species on the basis of course of charge. It can resolve many different hemoglobin products as well as common hemoglobin variants po. But here in ion exchange HPLC, remember, yung propensity po ng hemoglobin variants, shift base or carbamylated hemoglobin po, to interfere with the assay will depend po sa resolution ng specific assay na gagamitin po. Because any of the products may co-elute po with molecules of interest. Then we have enzymatic assays po. Enzymatic assays, on the other hand, use a 2-step reaction po to estimate hemoglobin A1C po. So first, yung proteolytic enzymes po will digest the hemoglobin. Tapos yan, deglycated N-terminal valine po undergo tinatawag nating deglycation, okay, which is coupled po with a chromogenic reaction po. and which is used to calculate also hemoglobin A1Cs po. By the way, this enzymatic again, these are not susceptible to analytic interference produced by the presence of hemoglobin variants po. And we also have capillary electrophoresis. Okay, capillary electrophoresis po separates hemoglobin po based on charge and hydrodynamic volume po. And the most common hemoglobin variants po, heterozygous hemoglobin variants po, for example, hemoglobin S, hemoglobin C, hemoglobin D, and hemoglobin E po have been shown not to interfere po. Again, they do not interfere with this assay. And of course, we have the boronate affinity chromatography po. This boronate affinity chromatography po uses common elution po to separate total glycated hemoglobin po based on the cis-diol groups po of hemoglobin-bound glucose po. So itong HbA1c in here, in boronate affinity chromatography, the glycosylated hemoglobin is calculated from the measured total HbA1c po and reported as a corrected equivalent po. So this boronate affinity chromatography has been found to demonstrate little to no interference po from the variants po, hemoglobin variants po. So, although any of these methods po may be used in the laboratory po, point-of-care testing po relies on immunoassay and boronate affinity chromatography po. Again, point-of-care testing for hemoglobin A1C po relies on immunoassay and boronate affinity chromatography po. And those that have the potential to presumptively identify hemoglobin or hemoglobin variants po, we have high-performance liquid chromatography and capillary electrophoresis po. The other methods like immunoassays, enzymatic assays, and boronate affinity chromatography do not presumptively identify hemoglobin variants po. So let's go to the alternative measures of blood glucose po. So non-enzymatic protein glycation po is not specific to hemoglobin po. Now, but most plasma proteins po, including, for example, albumin, immunoglobulin, haptoglobin po, they undergo irreversible linkage with glucose through the same step reaction. Of these, mention, yung mga plasma proteins po na na-mention, albumin po is the most abundant plasma protein. Remember, this accounts for approximately 60% po ng total extracellular proteins. So yan, it consists of a single polypeptide chain of about 500 amino acid residues po, divided into 3 domains. Now, as this albumin undergoes irreversible glycation as a function of blood glucose concentration over time, yung average blood glucose concentration po may be estimated using the fraction lang po, the fraction of glycated albumin or total glycated plasma proteins. Again, by the way, sa ibang books, magkaparehas po sila. Pero actually, magkaiba po yung GA and fructosamine po. GA or glycated albumin po is fraction lang po. Okay? Fraction lang po yan ng glycated albumin. While yung fructosamine po, that's the total glycated plasma protein po. But, by the way, despite the limitations po of glycated albumin po and fructosamine, they are highly correlated po. But, between the two, GA po and fructosamine, GA testing po is regarded as more specific and accurate than fructosamine po. So remember, the lifespan of serum albumin po is significantly shorter than that of red blood cells po. So as a result, again, lifespan po ng serum albumin po is shorter lang po kaysa sa red blood cell. Kaya, yung GA and fructosamine values, they only provide data on a patient's blood glucose status for the preceding weeks po. Hindi po pwedeng months. Again, preceding weeks. Now, although hemoglobin A1C reflects, or glycosylated hemoglobin, reflects a weighted average of blood glucose concentration over the preceding 100 days. Again, the weighted average of blood glucose concentration over the preceding 100 days. Ang GA naman po, or glycated albumin, this reflects glucose concentration over the previous 40 days po. And fructosamine naman, on the other hand, reflects glucose concentration over the previous 30 days po. So So as a result, GA po or glycated albumin and fructosamine po may be used to monitor short-term changes po in blood glucose concentrations po. For example po, recent change po sa gamot, recent change in pharmacotherapy. Other than that, in the same way that hemoglobin metabolism affects hemoglobin A1C, GA and fructosamine po are affected by conditions that influence serum albumin metabolism po. So for example po, decreased po yung GA or glycated albumin sa nephrotic syndrome po and hyperthyroidism. Bakit? Because increase po yung albumin turnover. Again, bakit decrease ang glycated albumin sa nephrotic syndrome and hyperthyroidism? Because of increased albumin turnover po. In contrast naman to this, increase naman po yung glycated albumin sa hypothyroidism po. So, yan. Because, remember, in hypothyroidism po, albumin metabolism is prolonged. Again, albumin metabolism po is prolonged in hypothyroidism po. That leads to increased glycated hemoglobin. Now, as a result, hemoglobin A1C po should be used to monitor blood glucose in these patients. Again, for patients po na may hypothyroidism po, HbA1c pa rin po yung ginagamit to monitor the blood glucose in the patients po. Itong fructosamine, by the way, general term again for glycated serum proteins because most serum protein is albumin, so proxy measure lang po yun siya ng glycated albumin. However, again, fructosamine po is non-specific po. Again, non-specific measure po si fructosamine of all glycated serum proteins po. And it is susceptible po to disease states po that cause metabolic derangements po. Kaya between the two, GA pa rin po yung mas preferred po. So for example po, patients with monoclonal gammopathy po, they have increased fructosamine concentration. Again, sa mga patients na may monoclonal gammopathy, increased po ang fructosamine concentrations. So, important to note po, many plasma proteins po will be elevated po as part of the acute phase response po. Again, many plasma proteins will be elevated as part of the acute phase response. That's why, hindi po ginagamit si fructosamine to estimate average blood glucose concentration during acute illness or sa injury po. Again, fructosamine po should not be used to estimate average blood glucose concentration during acute illness or injury po. Because many plasma proteins, remember, will be elevated as part of the acute phase response. Now, assays, just a short introduction. Assays to measure fructosamine and glycated albumin. We have fructosamine po is most often measured using colorimetry po. Okay, so this relies po on the unique property of glycated proteins po to act as reducing agents po. And the most common assay po for fructosamine is the NBT, or again, nitroblue-tetrazolium dye test. Okay, it measures the change of light absorption of 530 nanometer po. But, by the way, may mga nagkukos naman ng false increase dito sa NBT assay po. Substances that have been reported to cause artificially increased fructosamine by NBT assay, we have urate, we have glutathione, we have bilirubin po. Okay, and meron naman tayo na falsely depressed, okay? May mga interferences naman tayo which may, may mga substances naman tayo which may falsely decrease yung sa NBT dye test for fructosamine, we have cysteine, calcium, also hemolysis po. And also remember po, colorimetry po is sensitive to fluctuations po in ambient temperature po. Other than NBT, pwede din tayo gumamit ng enzymatic assay po. Almost same lang po with HbA1c enzymatic assay po. And glycated albumin, on the other hand, can be directly measured using the same methods po for HbA1c po. So, including, again, for GA po, pwede po yung mga methods ni HbA1c, like immunoassay, ion exchange, HPLC, and boronate affinity chromatography po. So, again, also, enzymatic assay po correlates highly po with GA values po obtained by HPLC po. So, yun. Okay, for number 5, which product is measured in the coupling step of the urease UV method for BUN? Again, which product is measured in the coupling step of the urease UV method for BUN po? Choices is letter A, Okay, carbon dioxide. Letter B, dinitrofenylhydrazine. Letter C, diphenylcarbazone. Or letter D, NAD+. Okay, is it NAD? Okay, correct answer po is letter D po. Again, letter D. So remember po that BUN po is most frequently measured po by the urease UV method po. So in which this urease UV method po uses a urease reaction coupled to a glutamate dehydrogenase reaction po, generating NAD. So you can see there. So urease po is used to hydrolyze urea po, forming carbon dioxide and ammonia. Now, glutamate dehydrogenase po catalyzes the oxidation po of NADH, okay? Forming glutamate from 2-oxoglutarate and ammonia po. So again, the glutamate dehydrogenase reaction is used for measuring BUN and ammonia po. So when the urease reaction po is, by the way, performed under the first order conditions, the decrease po in absorbance at 340 nanometer po is proportional po to the urea concentration po. For number 5, that's letter D. Okay, for number 6, in the Jaffe reaction, creatinine reacts with blank. Again, in the Jaffe reaction, creatinine reacts with blank. Choices, is it letter A, alkaline sulfasalazine solution to produce an orange-yellow complex. Letter B, potassium iodide to form a reddish-purple complex. Letter C, sodium nitroferricyanide to yield a reddish-brown color. Or letter D, alkaline picrate solution to yield an orange-red complex po. Correct answer po is letter D. So remember, this Jaffe method or the Jaffe method uses saturated picric acid which oxidizes creatinine in alkali po, forming, we call that creatinine picrate po. Now this Jaffe or Jaffe method po is non-specific. Why? Because this is subject to interference po. Proteins and other reducing substances po such as pyruvate, protein, and ascorbate po cause positive interference po. And much of this interference po is reduced by using a timed rate reaction po. So again, creatinine po can be measured po using an amperometric electrode din po. However po, this requires the enzymes, creatininase, we have creatinase, and sarcosine oxidase po. And of course, the last enzyme po produces hydrogen peroxide from sarcosine po, which is oxidized po. Now for number 7, a 45-year-old male of average height and weight was admitted to the hospital for renal function studies. He had the following lab results. We have the urine creatinine po is 120 mg per dl, serum creatinine is 1.5 mg per dl, total urine volume po in 24 hours is 1,800 ml. Question, now, how do we calculate the creatinine clearance for this patient in ml per minute po? Choices, is it letter A, 100, choice letter B, is it 144, choice letter C, 156, or letter D, 225 po. Ano ping answer natin? Okay, correct answer po is letter A po, 100. So remember, clearance, of course, this is the volume of plasma po that contains the same quantity of substance that is excreted in the urine in 1 minute. Now, this creatinine clearance is calculated po as the ratio of the urine creatinine to plasma creatinine in milligrams per deciliter po. This is also multiplied po by the volume of urine produced per minute po and corrected for lean body mass po by multiplying by 1.73 over A, where A po is the patient's body surface area. Pag given po yung body, yung surface area po ng patient po in square meters po. Although separate reference ranges po, of course, are needed for males, females, and children because each has a different percentage po of lean muscle mass. Okay, so how did we get the answer? First is we convert urine volume po to ml per minute. Again, we convert urine volume to ml per minute. So that's 1,800 ml yung given po. for 24 hours. So to convert that to minutes, that's 1,800 ml per 24 hours times 1 hour over 60 minutes po. We get 1.25 ml per minute po. Tama, again, 1.25 ml per minute. Next is we compute for the creatinine clearance. That's urine volume over the plasma. Tama? So that's 120 mg per dl po times 1.25 ml per minute divided by 1.5 mg per dl. We get 100 ml per minute po. Again, correct answer po is 100 ml per minute. For number 8, so in bilirubin determination, the purpose of adding a concentrated caffeine solution or methyl alcohol is to what? Is it letter A, allow indirect bilirubin to react with color reagent? Letter B, dissolve conjugated bilirubin? Letter C, precipitate protein? Or letter D, prevent any change in pH? Again, what is the purpose of adding a concentrated caffeine solution or methyl alcohol? Of course, correct answer is letter A. Again, unconjugated bilirubin is poorly soluble in aqueous solution. So it reacts very slowly with aqueous solution of diazotizing color agent po, unless, of course, an accelerating agent. For example, the caffeine sodium benzoate in Jedrasik Rough or the methanol or methyl alcohol in the Evelyn Malloy method is added. Now for number 9, in which of the following disease states is conjugated bilirubin a major serum component? Again, in which of the following disease states is conjugated bilirubin a major serum component? Is it letter A, biliary obstruction, letter B, hemolysis, letter C, neonatal jaundice, or letter D, erythroblastosis fetalis? Correct answer is letter A. So remember, in the prehepatic phase, as in hemolytic anemia or hemolytic disease, indirect bilirubin is increased in the blood. Negative urine bilirubin, that's negative conjugated urine bilirubin, of course, and positive urine urobilinogen po. Now, in the hepatic phase, okay, which is mainly associated with liver damage, so increased po yung indirect bilirubin and direct bilirubin sa blood. Yeah, urine bilirubin may be negative or positive, and of course, for urine urobilinogen, positive po. Now, for post-hepatic phase, as seen in obstruction or obstructive jaundice or bile duct obstruction po, increased po yung conjugated or direct bilirubin sa blood. Okay, but positive po yung urine bilirubin and negative or decreased ang urine urobilinogen. Now, for number 10, again, for number 10, turbidity in serum suggests elevation of what? Again, turbidity in serum suggests elevation of A, cholesterol, letter B, total protein, letter C, chylomicrons, or letter D, albumin. So the correct answer, again, is letter C, chylomicrons. Now for number 11, earliest marker po of acute myocardial infarction. Again, earliest marker of acute myocardial infarction. Choices, is it letter A, creatine kinase, letter B, lactate dehydrogenase, letter C, myoglobin, or letter D, troponin? Again, earliest marker po of acute myocardial infarction. Correct answer po is letter C, of course, myoglobin. So currently, this is the updated version from the National Institute of Health in the United States. So obsolete markers of AMI, we have aspartate aminotransferase or AST, total CK, and LDH po. Established markers, we have the troponin T, troponin I, we have the CKMB, we have the myoglobin, and also new. Okay, new or emerging markers po, we have heart fatty acid binding protein, we have BNP or B-type natriuretic peptide, we have ischemia-modified albumin and pregnancy-associated plasma protein A, as well as co-peptine. Now remember, myocardial infarction po, this is defined po as a myocardial cell death po due to prolonged ischemia. Now, AMI po is the major cause of morbidity and mortality worldwide. So this, the highest risk po of this fatality occurs within the initial hours of onset of AMI po. Hence, early diagnosis po ng cardiac ischemia po is critical for the effective management of patients with AMI. But remember po, myocardial cell death po does not occur po immediately following po the onset of myocardial ischemia po. But it occurs more or less 6 hours po after. Now, atherosclerosis, by the way, is by far po the most common cause of myocardial infarction po. So other than that, the major risk factors, again, the major risk factors po of atherosclerosis are hyperlipidemia, diabetes, smoking, hypertension, gender, and age. So in the year 1954, AST po was the first cardiac biomarker po to be used. So of course, alam po natin that AST po is found in the liver, heart, skeletal muscles, brain, and kidneys po. Now, due to its lack of specificity to the cardiac tissue, it is no longer used for the diagnosis of AMI. Now, in the year 1959, the total CK po level was assessed for AMI po, as it was also a good indicator po of skeletal muscle injury. Now, following this, pagkatapos po nito, in the year 1960, LDH naman po was used for the diagnosis of AMI po. And finally, in the year 1979, the World Health Organization recommended the panel of CK, AST, LDH, and LDH po for the diagnosis of AMI. However, yung assessment po ng cardiac biomarkers po was revolutionized po in the year 1980 po after na-develop po yung mga immunoassays. So let's go to the established markers. Like for example, troponins po. So the troponins, okay, these are a complex of 3 protein subunits po. Namely, we have troponin C, troponin T, and troponin I po. Located of course sa thin filaments po ng skeletal and cardiac muscle fibers po. Now, troponin C, kaya po troponin C ang tawag sa kanya, siya po yung calcium binding component. Troponin T naman is the tropomyosin binding component po, and of course, troponin I, why I? Because it is the inhibitory component po. Now, troponin C po is the calcium binding component. Again, troponin T is the tropomyosin binding component, and troponin I po yung inhibitory component po. Now, troponin C po, by the way, is not extremely specific po for myocardial injury. Again, troponin C po is not extremely specific for myocardial injury. Bakit po? Because the isoforms po of troponin C po is identical to the skeletal and cardiac muscle po. Now, on the other hand, the isoforms naman po of troponin T and troponin I differ in the skeletal and the cardiac muscle po. And thus po, they are extremely specific po for cardiac tissue necrosis po. So this troponin T, by the way, is present chiefly in the bound form po. Again, in the bound form to the contractile elements po of the myocardial cells po. Or sometimes naman po, it is present free in the cytoplasm. Now, this troponin T, again, by the way, exhibits a dual release po, initially with cytoplasmic component po, and later po of the bound component po. And yung troponin I, of course, this is extremely specific for the cardiac muscle po. And it has not been, by the way, isolated po from the skeletal muscle. So, this absolute specificity po ng troponin I po makes it an ideal marker of myocardial injury po. And remember, they are released into the circulation, again, troponin I po. This is released into the circulation po 6 to 8 hours after myocardial injury po. It peaks at around 12 to 24 hours and it remains elevated for 7 to 10 days po. Yung only disadvantage lang naman po ng troponin C, by the way, kanina na mention ko po, is the late clearance po. So relatively mas matanggal po to yung troponin C po, mas matanggal to siya or matagal to natatanggal or na-eliminate po. Okay, it makes it difficult po to identify a recurrent myocardial infarction po. And we also have the myoglobin po. Myoglobin naman po, this is of course a small cytoplasmic oxygen binding protein found in the skeletal po as well as the cardiac muscle po. So it is released extremely early po. Siya po yung earliest marker po into the serum 1 hour after the onset of myocardial injury. Again, 1 hour after the onset of myocardial injury, and it peaks po at 4 to 12 hours po. And it returns to baseline values immediately po. Pero yung major disadvantage naman ng myoglobin is that it lacks specificity po to the cardiac tissue po due to its, of course, presence po in large amounts sa skeletal muscle po. So, the levels of myoglobin can therefore not be used po as a single diagnostic marker po. But in conjunction po with the troponins or CKMB. So, thus, serum levels po ng myoglobin po can be used to rule out. Again, pwede po siyang gamitin to rule out rather than diagnose. Okay, myocardial infarction. And we also have CK and CKMB. Okay, CK po was, of course, first indicated as a cardiac biomarker po in the year 1979. So, CK po is an enzyme that is found primarily po in the cardiac muscle and the skeletal muscle. Of course, alam po natin yan, yung tatlong isoenzymes. We have CKMM, CKBB, and CKMB. Of course, CKMM is the skeletal muscle fraction. CKMB naman po is the cardiac muscle fraction, and CKBB po is the brain fraction of the total CK. So, remember po, yung CKMB, the CKMB po rises in the serum at 4 to 9 hours po. Again, 4 to 9 hours after the onset of chest pain. Also, it peaks at 24 hours po, and it returns to baseline values po at 2 to 3 days po. So, yung isang advantage po ng CKMB po over the troponins is the early clearance po. Mabilis po siya natatanggal sa system po. Matagal po siya natatanggal, sorry, that it helps po in the detection of reinfarction. So, kaya nga po yung serum level po ng troponin along with level of the CKMB po is assessed for the diagnosis of myocardial infarction. Now, let's go to the emerging markers naman po. Okay, so introduce ko lang po, we have the heart fatty acid binding protein, or we call that as HFABP. So this is a small, low molecular weight protein po found in the cardiac tissues po that are responsible for the transport of fatty acids po from the plasma membrane to sites of beta oxidation po sa mitochondria po. So also sa endoplasmic reticulum po for lipid synthesis po. So this HFABP po is chiefly present po in the myocardium, and to a lesser extent po sa brain, kidney, and skeletal muscles po. So this is extremely early into the serum po following a myocyte rupture. So as increased concentration po nito appears as, an increased concentration po ng HFABP po appears as early as 30 minutes po after MI. It peaks naman po at 6 to 8 hours, and it returns to baseline values po at 24 hours po. So, HFABP po, remember, is a predictive biomarker of mortality po following acute coronary syndrome. Again, HFABP can be used as a predictive biomarker of mortality po following acute coronary syndrome. And we also have the B-type natriuretic peptide po. This BNP po, this is a neurohormone released from the cardiac cells po. Now, studies have shown po that elevated BNP po is a predictive marker po of death and heart failure po. However po, BNP po is not useful po for the diagnosis of AMI. And we also have the ischemia-modified albumin po. So, under ischemic conditions po, yung level po ng IMA sa blood is significantly increased po, thus aiding in the diagnosis of acute ischemia po. Prior, of course, before yung onset po ng MI, myocardial necrosis. Now, the measurement of IMA po is enabled po by the binding po of the cobalt po to the damaged end terminus of the albumin po. So, increase po yung IMA levels po, nag-increase po yung IMA levels immediately po after ng onset ng ischemia po. And it returns to baseline values within 6 to 12 hours po. Again, within 6 to 12 hours po, thus enabling early identification of ischemia po. And we also have, by the way, copeptin. So, copeptin naman po, okay, this is the C-terminal portion of provasopressin po that is co-secreted with vasopressin po. This is secreted by way extremely early po in the course of an AMI po from the pituitary. Again, from the pituitary. Now, this the levels po of this copeptin po are significantly increased po within minutes in the patients with AMI po. So, ginagamit po tong copeptin as a prognostic marker of myocardial injury. For number 12, up to 10% of cases po of acute pancreatitis are associated with normal levels of amylase. This finding is not common in people with, again, up to 10% of cases of acute pancreatitis are associated with normal levels of amylase. This finding is not common in people with, is letter A, hypernatremia, letter B, hyperkalemia, letter C, hyperbilirubinemia, or letter D, hypertriglyceridemia po. The correct answer po is letter D, hypertriglyceridemia po. So remember po, this amylase is commonly measured po using synthetic substrates po. So this amylase, the IFCC, by the way, recommended method po, okay, for amylase po, uses the p-nitrophenyl malto hepatoside po. Now, one end of the polymer po is covalently linked to the paranitrophenol po, and the other is linked naman po to the ethylidene po to prevent its hydrolysis po. So, amylase hydrolyzes the substrate from both ends, producing fragmented glucose subunits po. Now, serum amylase, remember, usually peaks 2 to 12 hours po following acute abdominal pain resulting po from pancreatitis po. And levels reach 2 to 6 times po the upper limit po, and they return to normal levels within 3 to 4 days po. Also take note po that urinary amylase po peaks concurrently po with serum but rises higher po and it remains elevated for up to 1 week.